Chronic non-cancer pain treatment is shown here. How do you describe this? What is this? Who described this sort of?
WHO pain ladder.
Is it the original pain ladder treatment or the modified one?
Original one, sir.
Original. Four steps were there in the original itself?
3 steps were there in the original.
3 steps, sir. One was added.
Original, yeah, there are only 3. The revised 4-step analgesic ladder for chronic non-cancer pain. Okay? Earlier it was only 3 steps. Step 1, step 2, step 3. So what was the earlier treatment ladder? Only 3 steps here. Okay, 1986, WHO induced 3-step analgesic ladder for chronic pain management, which mainly consisted of these 3 steps. Okay. Step 1 is non-opioid with or without adjuvant analgesic for mild pain. Second thing is mild to moderate pain. Step 2, opioid for mild to moderate pain plus non-opioid plus adjuvant. Then moderate to severe pain, opioid as the primary thing plus non-opioid plus analgesics. And so this is the plan, persistent move by step you have to go, and then bring it down slightly. Once you find that you are exceeding the dose and going for toxicity, you have to slowly try to reverse back to that. This is the original 3-step WHO pain analgesic ladder, which is called. Now here it has been modified as a strong opioid analgesic and non-opioid analgesic adjuvant, because here minimal invasive intervention has been included in the 3rd step, and a non-opioid analgesic and adjuvant analgesic. So the step 3, where we were using opioid for moderate and severe pain, has been removed from step 3. It has been taken to step 4. And here minimally invasive interventions like blocks and other things have been added. So that is the reason why it has been modified as a step 1 where no opioid at all. So non-opioid with adjuvant, weak opioid, non-opioid and adjuvants, minimally invasive in step 3 like interventional blocks or IFP and other conservative measures. Then step 4 goes for the strong opioid analgesic and non-opioid plus adjuvants. That is the. So what is the need to revise the earlier one? Why the 3-step ladder has been made into 4-step ladder? Intervention therapies were not included in the earlier version. So when people started using interventional therapies, it needed to be included. So they have to naturally revise that from 3 to. So usage of strong opioids in step 3 of the ladder had its own drawback like addiction, opioid-induced complications, specifically opioid-induced hyperalgesia. So because of that, they have to revise this into 4 steps. What is the definition of chronic pain? How do you define chronic pain? Is it based on duration or severity or any other adjective is there to define the chronic pain?
Pain persists or recurs after for more than 3 months.
3 months, very good. Duration 1. Anything else? Any other adjuvant? So pain without apparent biological value, because pain is, as all of you know, is a protective phenomenon. When you get traumatized, when you suffer an injury, the pain only tells you that there is a tissue damage. Okay, and it should be reasonably alleviated within a particular time. So the normal pain that we suffer from a trauma or other condition is an indicative of something wrong in the body, and it is considered as a protective phenomena or it has a biological value. But if you have a pain where there is no biological value and if it persists beyond 3 months, it is called chronic pain. So how this is classified and give examples for each. How can you define chronic pain? And what categories you can define them? Can be inflammatory, neuropathic, or dysfunctional. These are the three categories: inflammatory chronic pain, neuropathic chronic pain, dysfunctional chronic pain. So the examples are: inflammatory is due to tissue damage by trauma or infection. This is a short-lived one usually, and for a proper control of the treating the trauma or infection, it will this is the most easily curable chronic pain. The second thing is neuropathic primary lesion in the peripheral or central nervous system. Examples are phantom limb pain, carpal tunnel syndrome, all these things. The third is dysfunctional is a poorly localized pain, neither due to inflammation nor due to nerve injury. Examples are fibromyalgia, irritable bowel syndrome, and all. So this dysfunctional pain is the most difficult chronic pain to treat. Other things are comparatively easier to treat. What is being shown here?
Renal countercurrent mechanism.
Counter current mechanism. Those mainly counter current mechanism which helps to concentrate the urine form. Okay. How does urine formation occur? What are all the steps in the formation of urine?
Glomerular ultrafiltration,
Desorption.
tubular secretion.
Secretion. Very good. Three steps. So it's mainly by glomerular filtration minus tubular reabsorption plus tubular secretion. Okay. These are the three things that produce the urine in a very simple way. So how is the filtrate turned into urine? The filtrate is a large volume, as all of you would be knowing. How much of filtrate occurs in a day? How many liters of filtrate occur? 180 liters. Okay, for 24-hour period, the glomerular filtration is about 180 liters, 180. But the amount of urine we produce is only 1.5 to 2 liters. Okay, so the rest of it all is reabsorbed. So the reduction in volume, acidification, rise of osmolarity, complete absorption of some of the items that are filtered, and secretion of some of the items. These are the simple 5 steps in the formation of urine. What substances are reabsorbed from the proximal convoluted tubule and by what mechanisms?
99% of the water, sodium, bicarbs.
Glucose also, sir. Reabsorb.
Glucose, yes. And what mechanism? Is it by active transport or passive concentration based?
Water, glucose, and
glucose,
sodium passive.
all glucose, amino acids, vitamins, most of sodium, water, chloride, bicarbonate, and potassium. Most of the things are reabsorbed from the proximal. The mechanism may be primary active transport, like for sodium and potassium, secondary active transport for sodium, glucose, and amino acids, and passive transport for water, urea, and ions. These three mechanisms. What is countercurrent multiplication? This picture, first picture showed the countercurrent mechanism, or what is called, what is countercurrent multiplication? What multiplies? It's occurring in the loop of Henle to produce medullary osmotic gradient by different permeability of the descending loop and ascending loop. Okay, so the main purpose of countercurrent multiplication is to produce a medullary osmotic gradient. That is the tissues outside the loop of Henle, the nephron, they should be having a higher gradient, osmotic gradient to suck out water. That is another mechanism to reduce the volume. And what is countercurrent exchange? Several basic renal physiology questions. Okay? So this takes place in the vasa recta, that is tubular straight capillary, to preserve the medullary osmotic gradient. So multiplication is to make the medulla more higher, become a highly osmotic agent, and countercurrent exchange is to preserve that gradient by preventing washdown, achieved by minimal blood flow to medulla. So that is the mechanism. What is evidence-based medicine? Difficult questions. It's a conscientious, explicit, judicious use of current best evidence in making decisions about the care of individual patients. Okay, this is the definition of evidence-based: conscientious, explicit, and judicious use of current best evidence in making decisions about the care of a patient. What are the components of evidence-based medicine? They all new to you. Okay, best evidence available, practitioners' clinical expertise, patients' values and preferences. These are considered the components. Best evidence available, practitioners' clinical experience or expertise, and patients' values and preference. So it becomes this Venn diagram: clinical expertise, patient values, and practitioners' available evidence. Now, what is evidence-based pyramid? So instead of that Venn diagram, can sometimes have evidence-based pyramid where are layers here. The base is ideas or opinions. Second is case reports, case series, case control studies, cohort studies, randomized control trial, and randomized controlled double-blind studies. This is the ultimate RCT double-blinded. That is considered as the super evidence for any treatment. All other things are lesser. So from acceptability or value wise, it starts from your own opinion. Somebody can say, I have done 1,000 cases. In my experience, I have not come across this, or I can have seen several cases like this. That goes to the bottommost part of the pyramid. So if there is a RCT with a double-blind study, and that proves what this man says is correct, then we can have the possibility of this accepting that particular treatment. So this is the pyramid. So it's a stepwise approach, starting with ideas and opinions at the base and going through case reports, series, control studies, cohort studies, ultimately to randomized control trials. What are the various levels of evidence? All of you would have heard about levels of evidence and recommendations. This is the two things which you have to remember if you want to remember evidence-based medicines. So evidence is divided into levels and treatment is divided into recommendations. So the levels are: level 1 is evidence from at least one randomized control trial. Then it is called level 1 evidence. Level 2 is evidence from well-designed control trials but no randomization, or from cohort studies, that is equivalent to what is this pyramid showing, and case control studies, or multiple time series designs with or without interventions. So this is called level 2. Level 3, opinion of respected authorities based on clinical experience and descriptive studies. So there are only 3 levels of evidence: level 1, level 2, level 3. If there is a level 1 evidence, that is the best evidence because it is based on randomized control trial. If the evidence is level 3, that is the least accepted evidence because it is by respected authorities on clinical experience and descriptive studies and not based on any randomized controlled trial. Now, what are the categories of recommendations of treatment? That is classified into A, B, C, D, and E. A means strongly recommended because of strong evidence from a randomized controlled study. B means it's a strong or moderate efficacy limited to clinical benefit, generally recommended. And C is there is insufficient evidence, but with if you can assess the risk benefit ratio, then you can opt it. You can accept it or you reject it, optional. D is there is moderate evidence, but not generally recommended. And if it is recommendation E, it is a strongly negative thing, never recommended. So remember these two things. Evidence is level based, level 1, 2, 3. Recommendation is value based as A, B, C, D, E. So normally we combine both these things to decide about the treatment in evidence based medicine. So even if it is asked as a question in your theory exam, with these few points you can certify a jalebi for your answer. Okay?
Yes, sir.
What is the compression to ventilation ratio giving CPR to any individual? The answers are A,
30.
B, C, D. Huh?
30:2, sir.
B, very good. When performing 2% CPR, how often should you change roles? The options are after 1 cycle, after 2 cycles, after 5 cycles, after 10 cycles.
After 2 cycles or when the CPR person is exhausted.
Answer is C. After every 5 cycles, you have to change roles. Okay. In operating an automated electrical defibrillator, what are the correct steps? There are 4 options. And instead of A, B, C, D, I type A, B, sorry. So power AED, attach pads, shock analyze rhythm, then power the machine, attach pads, analyze rhythm, clear individual and shock, attach pads, check pulse, shock and analyze rhythm, check pulse, attach pads, shock and analyze rhythm.
B, sir. Power
Sir.
AED
Correct,
attach
correct.
parts.
This is a very important thing. Clear all individuals. This is a very important thing before you shock. You must shout clear, and then only shock the patient. Okay, that is an important algorithm that you have to make sure that nobody else gets electrocuted other than the patient. So, what are the BLS steps used for adult rescue? The options are assess individual, give 2 rescue breaths, defibrillate, start CPR. Assess individual, activate EMS, get AED, check pulse and start CPR. Check pulse, give 2 rescue breaths, assess individual, defibrillate. Assess individual, start CPR, give 2 rescue breaths and defibrillate.
B, sir.
B, yes. You must see the word EMS. That is very, very important in BLS. Before you start that, your resuscitation, you must intimate the emergency medical services so that they will arrive early and transport the patient if necessary. So B is the option, correct. What are the features of first grade CPR? Options are starting chest compression within 10 seconds of arrest, pushing hard and fast, minimize interruption, all of the above or none of the above?
All of the above, sir.
All of the above, correct. D, right. What steps, which step is not part of steps in adult chain of survival? That is early CPR, rapid defibrillation, advanced airway placement, and integrated post-cardiac arrest care.
Rapid defibrillation.
Huh?
B, sir.
D, integrated or rapid?
B, rapid defibrillation.
Is it not part of adult chain? Don't you start
Advanced
with the
airway placement.
Advanced airway placement.
advanced airway placement is not part of the chain. Okay, intubation like fiber optic or laryngoscopic intubation is not mouth to mouth or ambu ventilation is only considered as a part of BLS, other chain survival. Okay, what is the recommended sequence of BLS from 2015 guidelines? One is chest compression, airway breathing, or airway breathing check pulse, airway breathing chest compression, none of the above.
Airway breathing check pulse.
Option A
means
is
B.
chest compression, airway and breathing.
Airway breathing check pulse.
Yeah, always
Circulation
chest
first and
compression.
then.
Earlier it was ABC, airway breathing circulation. It was changed to chest compression first in 2015 itself. Nowadays we say pulse, compression only, life support. That is the current thing. 21 recommendation is pulse, compression only, life support. If necessary, give rescue breaths. So they are not giving much importance to airway and breathing. More than that, they have found that proper, correctly given chest compressions have better results. How many breaths should be given during 2 rescues or CPR in adult with advanced airway placement? Options are 20 to 30, 12 to 15, 8 to 10, and 5 to 6. Patient already has an endotracheal tube, and you are bagging with the ambu bag. 8 to 10, okay? Because if you hyperventilate, you will be not allowing CO2 accumulation to stimulate the respiration. And if you hypoventilate, hypercarbia will occur. So they have found 8 to 10 is the ideal number of breaths. What is shown? What is this baby having?
Congenital diaphragmatic hernia, sir.
Excellent. Congenital diaphragmatic hernia and a newborn. What are the types of congenital diaphragmatic hernia?
The anterior, the Bochstock and Morgagni, posterolateral descent and anterior.
Yeah. The correct type answer is it may be right, left, or bilateral. Okay, give right side or left side or bilateral, and the defects placed on the diaphragm according to the location of the hole in the diaphragm. How is it classified?
Posterolateral and anterior.
Any names for that?
Bochstock and Morgagni.
Bogdaglac and Morgagni. Very good. What is eventration of diaphragm? The diaphragm is weak but no holes. The diaphragm is intact but it is weak. Then it is called eventration. What is the pathophysiology of congenital diaphragmatic hernia? How does it? What are the things that happen in this condition? So 3 things happen. One, you can have pulmonary hypoplasia if it happens at a very early stages of gestation. Once pulmonary hypoplasia occurs, it will cause vascular remodeling and pulmonary hypertension because the lung is not developing, the vessels are all very constricted and they become resistant and pulmonary hypertension develops. And because of this, there is no adequate blood flow and the left ventricle also will become hypoplastic. So that is how the whole thing changes. What is the immediate management of a baby born with congenital diaphragmatic hernia? What is the newborn resuscitation you should do?
Rise tube.
Rise tube. There are so many things, immediate
Avoid
intubation,
mass.
monitoring pre and post ductal saturation, aiming for a post ductal saturation between 80 and 95%. Nasogastric insertion with frequent continuous suction, IV access either through umbilical line or transfer the patient to ICU, invasive blood pressure monitoring. These are all the important immediate treatment that we should give. What is the algorithm that has to be followed for the management of congenital diaphragmatic hernia? There's an algorithm that is available. Can you make a guess of what is that? Okay, I'll just show you. Initial monitoring and investigation. You can put a radial artery cannula, and pre and post saturation, assess PR jet, everything, and, ultrasound of the heart, head and kidney. And then aims are pre-ductal saturation must be 92%, post-ductal saturation 80 to 95, PaO2 more than 7.5, PaO2 less than 6, and mean arterial blood pressure 45 millimeter minimum or appropriate to the age. So these are the important monitoring investigation and aims. And if already patient has pulmonary hypertension, then you can assess good respondents, poor respondents, and then based on that you can do all the investigations and treatment. And once in the event of further deterioration, how to maximize hemodynamic support, and then optimizing ventilation, repeat echo, consider ECMO. So the basic thing you have to understand in congenital diaphragmatic hernia is what is the status of the lung on the side of herniation. If the lung development is very premature, not developed well, those babies do not do well. On the contrary, if the lung has developed well and it is a late occurrence of herniation, those babies will do very well by reducing the hernia and closing the rent in the diaphragm. This is the basic thing that you have to understand. Now, what is FETO? FETO. How does it help in congenital diaphragmatic hernia? What is the expansion for the acronym FETO? Have you heard of the terminology? One of you?
Tracheal occlusion we do
Called
fetal surgery.
fetoscopic endoluminal tracheal occlusion. The minimally invasive transuterine intervention. It works by deploying a balloon in the fetal trachea. So they pass a balloon, Police catheter-like thing, or Fogarty catheter-like thing into the trachea and inflate the balloon and occlude the trachea. Because the baby is not breathing, you don't have to worry. You just close the trachea. This acts to prevent the efflux of pulmonary fluid from the trachea by way of occlusion. So that will stretch the fetal lung, accelerating lung growth. So this should be done. If you detect it, nowadays it can be detected by ultrasound. The very early stages, as early as first trimester, you can identify that. And once if you do this procedure, it will stretch the lung and help it in growth and remodeling the pulmonary arterioles and prevent pulmonary hypertension development. And the balloon can be removed when the baby is 32 to 34 weeks of gestation. Okay? So it should be introduced as early as possible and removed at 32 to 34 weeks. By the time the lung would have developed adequately for the baby to survive without developing a severe pulmonary hypertension. Now this is a case scenario. 25 years old primey at 28 weeks of pregnancy complains of severe right iliac fossa pain with nausea and vomiting, diagnosed to have twisted ovarian cyst. She is planned for a laparoscopic excision of the twisted cyst. What are the challenges in the anesthetic management?
It can be divided into mother and baby.
Mother and baby.
Preterm labor, and since she falls under last trimester, we can take a supposition of
Okay.
Since it's post 28 weeks, high risk of aspiration for her.
So this patient is in her third trimester of pregnancy. So there is no fear of teratogenicity because organogenesis is complete. So you can use all drugs or all techniques. So organogenesis is complete. So no fear of teratogenicity. Number one. Okay. But there are two problems that can happen. One is premature labor and birth of a premature baby. Okay, because it's only 28 weeks, baby will be very premature. And any intervention at this stage can produce a premature labor. Now she needs a thorough evaluation to assess her general health, welfare of the fetus, and rule out any pregnancy-induced complications like gestational hypertension, diabetes mellitus, kidney disease, or preeclampsia, or any occult valvular lesions should be ruled out. And all regular investigations, including airway evaluation, to be done. And problems can be classified: one associated with pregnancy, two associated with the lap type of surgery. Okay? And problems pregnancy related: position, you have to give a left lateral tilt, aspiration prophylaxis, pre-oxygenation because they have a low FRC, CVS stability for fetal and maternal safety, and you must use tocolytics to prevent premature labor. Intraoperative fetal monitoring should be done. And hypercoagulable state will be there, so chances of thrombus formation. These are all the challenges related to pregnancy. Now, challenges related to lap surgery are: it will alter the CVS, RS, and renal physiology due to pneumoperitoneum. CO2 absorption will affect the fetal oxygenation because normally maternal blood will be respiratory alkalosis or acidosis.
Alkalosis.
Alkalosis. Mother hyperventilates and her normal PaCO2 will be between 30 and 35, not 40. Why this alkalosis is there in the mother? What is the purpose of this nature making the mother's blood a little alkalotic with a low PaCO2 rather than normal PaCO2 of 40? Only the fetus can exchange its carbon dioxide because carbon dioxide comes because of the concentration gradient. So if mother has 40 or 45 and fetus also has 40, can carbon dioxide come out of the fetal blood into the maternal circulation?
No, sir.
No. So that is the main reason. So there is a fetus will have 40 millimeters, mother will have 35 millimeters. So CO2 will cross through and come to them. Okay. And raised intra-abdominal pressure compressing uterus. These are the challenges of that. Name the parts of a typical vertebra.
Body, intervertebral foramen, facets.
Intervertebral foramen, is it a part of a vertebra or vertebral canal? You mean?
Vertebral canal.
Intervertebral foramen is between two vertebrae. That doesn't form the part of the vertebra. Okay. When two vertebrae are lying adjacent to each other, there is a gap which is called the intervertebral foramen. But already you know there are markings here. This is body. Okay. What is this portion? Are you able to see my marker, arrow mark?
Yes, sir.
No, sir.
What is that portion of the vertebra called? This is the pedicle. Okay. And what is this is called?
Articulating facets.
This is articulating facet.
Transverse process.
This is transverse process. Okay. Pedicle, transverse process in continuation of the whole thing, not this blue thing. The whole thing is called, that is from the transverse process up to this. What is this process? Spinous process. So between transverse process and spinous process, what is the communicating bone?
Lamina.
That is called lamina. Very good. When you do laminectomy, the neurosurgeons remove this only, okay, to release the pressure. And this is the articular facet. Okay, so body, pedicle, transverse process, lamina, spinous process, articular facet or facet joints. Okay, so these are all the parts: body, pedicle, transverse process, lamina, spinous process, articular facets, and central vertebral canal. What is shown here? You can see somebody is back.
Taylor's
2 points
approach.
here.
Caudal, sacral hiatus for the
Taylor-
caudal.
Sacral hiatus is here.
No, sir. L5
Taylor's
L5
approach. L5
Huh?
and
Taylor's approach for spinal.
Taylor's approach, very good. Who said that? Fantastic. Okay. Shows the anatomical landmarks for Taylor's approach to subarachnoid block. Okay. Here there is the needle is going from here. It is entering the space between L5 and S1. That is sacral origin. Okay. So what are the indications for this approach, Taylor's approach? When will you do this? This is not normally practiced. So the anatomical landmark for this is the posterior superior iliac spine, 1 centimeter below and 1 centimeter medial. That is the point of entry of the needle. And if you go in that direction and aim towards the midline, you will go through the biggest intervertebral space, or the space between L5 and S1. That was the idea of Taylor's approach. This is indicated in patients with deformed spine like scoliosis or arthritis. For example, you can see this is the patient who has such a crooked spine, scoliotic spine. Okay, so they have entered from here and then entered into the space, and you can see the CSF fluid coming out. So how do you diagnose and treat total spinal? What are all the changes that you will see in total spinal, and how do you treat it? Have any one of you seen a case of total spinal?
No, sir.
Oh, that means you are all very safe anesthetists. Very good. So when you do total spinal, the drug travels up to the foramen magnum and beyond that into the cranial cavity. That is what is called total spinal. Okay. So because it goes so high up, it will affect or block all the cardiac accelerator fibers. So it will produce bradycardia, hypotension. Because of that, patient may have nausea, vomiting. The immediate treatment is to give atropine, ephedrine, and phenylephrine. And patients may, if the initial stages, they may complain of tingling of hand with progressive weakness in hand grip. All you have to do is reassure the patient, give reverse Trendelenburg, that is head up position, to prevent further spread. They may have difficulty in breathing, difficulty in phonation, and desaturate. To assess airway, give oxygen supplementation. If required, you can intubate the patient. Suddenly, they may stop breathing. They may go for a respiratory arrest, and you won't require any relaxant because the whole muscle will be paralyzed. You can just put in a scope and put in a tube without vocal cords are not moving. It will be like a scoline intubation. Such flaccid paralysis will be there. So you have to intubate and ventilate. And sometimes they may also have slurring of speech and suddenly lose consciousness. Then call for help, ABC, rapid sequence intubation and ventilation, circulatory support with sympathomimetics and vasopressors and fluids. If it is a xylocaine total spinal, you need not worry. It will revert back within 1 hour, 1.5 hours, and the drug effect goes on. All you have to do is stimulate the heart, keep the baby, ventilate the patient, maintain saturation. But if it is lignocaine, bupivacaine, it may take a little longer. But these cases can be easily salvaged by timely intervention and support of respiration and circulation. What is toxicity ratio, and what is the value for lignocaine and bupivacaine for this?
The ratio
heard
of
of
the
this term?
CNS, yes, the CNS to CVS effects.
Normally, which one will be occurring first? If there is a local anesthetic toxicity, which symptoms will be exhibited first by the patient? CVS or CNS?
CNS. Oral numbness.
Circumoral numbness, tingling, then some agitation, okay, excitedness, then the drowsiness, coma. Okay, that is how the whole thing will happen. So initially it will be the CNS toxicity. Later on it will go on to CVS toxicity of bradycardia, hypotension, and arrest. Okay, so the blood value or the serum concentration required to produce CNS toxicity compared to the cardiovascular toxicity is called the toxicity ratio. So it is the ratio of long LA drug, that is local anesthetic drug concentration in the blood to produce CNS and CVS toxic effects is called toxicity ratio. It is 3 for bupivacaine. That is why bupivacaine is considered very unsafe drug, because only 3 times more than the concentration required to produce CNS toxicity is required for cardiovascular toxicity. Whereas lignocaine, it is 7. So you, even when you have tingling, numbness, circumoral numbness, and other things, you require 7 times more concentration to produce a cardiac arrest. So you will take a longer time to result in cardiovascular toxicity, and it will be easily reversible. Whereas bupivacaine attachment is also very strong, so reversal also will be difficult, and the safety also is very low. So in order to avoid this only, we have now come out with the levobupivacaine, okay, which has got a value of almost 5 to 6, okay, which comparable to lignocaine. So the cardiovascular toxicity is much less with levobupivacaine compared to lignocaine. Will we stop here? There are so many other things. We'll see next week. Okay.